Great, thank you very much for asking me back. Sure I know what I'm doing. Okay, so I'm a cardiologist and I specialise in adult congenital heart disease, and with that remit I look after the pulmonary hypertension side of things, so I do a shared care agreement with Sheffield team. So I try and keep pulmonary hypertension quite simple. Obviously there's specialist centres around the country with all the expertise. You have to remember they have one disease to manage, so of course they're experts at it, and they have about 6 drugs, so you can feel superior that way. So don't tell them I said that either. Okay, so learning outcomes. So what I think that you should get from this lecture is to have an understanding of how we classify pulmonary hypertension and the basic pathophysiology. Most importantly for me is for you to be able to identify a patient. So you have that level of suspicion that this might be pulmonary hypertension, and then understand how we would diagnose them, and then have some understanding of the management options for these patients. I've just selected some useful reading here. So the top one is the ESC ERS guidelines that are really extensive, very easy to read. David Kiley's team wrote a really good review back in 2013 that is still very current, and then there's this other one from Hart in 2015. So they're all good papers to start with. So, question 1. That should be open. So which of the following correctly diagnoses pulmonary hypertension? So 1, mean pulmonary artery pressure greater or equal than 25 at rest or greater than 30 during exercise. 2, TRV max 3.6 metres per second, dilated pulmonary artery. 3, mean pulmonary artery pressure greater or equal than 25 and PCWP less than 15. 4, TRV max 4 metres per second with evidence of RVH. Or 5, mean pulmonary artery pressure greater or equal to 25 at cardiac catheterisation. So, none of these are designed to catch you out either. Still going up. Okay. Right. Okay, so slight majority put number 1, which is at rest and exercise. Second is the number 5. So this is actually the right answer. Okay, so they've actually taken out the exercise because it wasn't quantified. It didn't really mean anything. So you diagnose pulmonary hypertension. So this is the diagnosis: the mean pulmonary artery pressure greater or equal to 25 millimetres of mercury measured at cardiac catheterisation. So no mention of exercise anymore. So this one's a bit blurred, sorry. So this is your clinical classification. So it's now divided up into 5 groups. And the one that we all sort of think about pulmonary hypertension is your pulmonary arterial hypertension. So this is your precapillary pulmonary hypertension. You've got your idiopathic pulmonary hypertension, hereditable, drug and toxin. This is the one that I see mostly, the 1.4, so it's associated, there you go, with congenital heart disease, HIV, connective tissue disease, very prevalent, portal hypertension, schistosomiasis. The ones as general cardiologists that you'll see most frequently is going to be the pulmonary hypertension due to left heart disease, incredibly prevalent, lung disease and hypoxia. This is your CTEPH and slightly more unusual causes of pulmonary artery obstructions. So people would say congenital pulmonary arterial stenosis. And then you've got all this unclear or multifactorial mechanisms. Okay. I think, do you all get copies of these slides?
Yes.
Yeah, you do. That's fine. So there's lots of it on here. But this is just different ways of sort of classifying it by the hemodynamic and the pathophysiology. So looking at your precapillary, so your pulmonary arterial hypertension, or your lung disease, your CTEPH. So this is what we said. You've got to have your mean PA pressure greater or equal than 25, and your wedge pressure is less than 15. Okay. Your postcapillary, so this is your pulmonary hypertension due to left heart disease, or some of those odds and sods in number 5, and this is when you've got that higher wedge pressure, okay? And this is from that paper that I referenced at the start that just shows you sort of breaking it down into your right heart, pulmonary vascular bed, left heart, aorta. So sort of have a look at that. This is the paper that always gets shown for the pathophysiology. You've got 3 pathways. So as well as one disease and about 6 drugs, they've got 3 pathways that they have to remember. You've got your endothelin pathway, your nitric oxide pathway, and your prostacyclin. And when we talk about the drugs a bit later on, it always comes back down to those 3 pathways. So the endothelin pathway, that's bad, isn't it? So endothelin, it promotes vasoconstriction and proliferation of cells. Nitric oxide pathway, it's protective, it's vasodilatation, you get anti-proliferation, and then also your prostacyclin pathway, you get the vasodilatation and anti-proliferation. So you've got those 3 pathways all involved with the pathophysiology, and it's the drug companies that are targeting all those 3 different pathways. Okay. So, epidemiology. It's fairly rare. There's a UK registry, probably about 97 cases per million. It's more prevalent in women than men, okay, especially the idiopathic and hereditable. European registries, this has only looked at the idiopathic, hereditable or drug-induced. So pulmonary arterial hypertension altogether, 5 to 10 cases per million per year, idiopathic 1.3 to 3. So it's still really small numbers, which is why that it's the specialist centres are so important, because you need to have all the expertise in small numbers of centres. We know that there are some conditions that are much more at risk of developing pulmonary hypertension. Connective tissue disorders, especially your systemic sclerosis, okay? So the CREST syndrome, right? Portal hypertension. If you look at these numbers, they're really quite prevalent in these conditions. Congenital heart disease, we always quote 5 to 10%. I think in the modern day practice, that's actually much lower than that. That's taken into account the Eisenmengers, when it was much more likely not to have surgical repair of large defects, but we're still seeing it in a significant number of people. HIV, 0.5%. Multiple recurrent or unprovoked PEs. Some papers quote a incidence of pulmonary hypertension of up to 4%. So you really just need to have that awareness of those patients who have had those big PEs or recurrent PEs that are breathless and not responding to therapy as you would expect. Think about whether they've developed pulmonary hypertension. Genetics, only really relevant in your group 1, to your pulmonary arterial hypertension. There's a mutation of the BMPR2, so that's your bone morphogenic protein receptor. And there's also some abnormalities with your SMAD gene as well. And you find these mutations in 70% of the patients who have got a family history of pulmonary hypertension. So about up to 40% of patients with idiopathic. It's a really low penetrance. So actually, if you're a carrier, you've still got a low chance of developing it, so about 20% chance, and you probably need multiple hits, so maybe you've got a coincidental ASD or some other condition can develop it. Okay, so question 2. So, in pulmonary arterial hypertension secondary to associated conditions, what is the leading cause? So 1, systemic sclerosis, 2, portal hypertension, 3, congenital heart disease, 4, HIV, 5, rheumatoid arthritis. Let's just see whether you've been listening. You there? I see a few more people have voted in that one. Let's see what you said. Absolutely, yeah. So systemic sclerosis, it's about 9%. Congenital heart disease, I said 5 to 10%. So, but systemic sclerosis is the one that's the most commonly associated with it. HIV was about 0.5%. Okay. So, next step is, how do these patients present? So we've talked about how it's really important to identify them. So what are their symptoms? Probably the commonest would be progressive shortness of breath, exercise intolerance. It tends to be quite gradual, so you'll find the patients will modify their own lifestyle, so that might sort of take a while to come out. Fatigue is a really important one that we really never ask about, but it's just that fatigue. You know, how do you feel at the end of a day at work? Do you have to have daytime naps at the weekend? Can you go go out in the evening, and that fatigue is one they really do hide, but it's very obvious when you find it. They might get exertional dizziness, they might get syncope if it's quite severe pulmonary hypertension. Angina, I've never seen angina with marked RVH, but it's reported. If it's got significant right ventricular failure, they get edema and ascites. Young people don't tend to get edema until quite late. Atrial arrhythmias, again when it's advanced. Hemoptysis, it's very rare, and this is just a nice post-mortem specimen of pulmonary artery with extensive thrombus within it. You can see where they get hemoptysis. So, going back to your membership examination, so the clinical signs of pulmonary hypertension. So the one that we all remember is a loud P2. So your pulmonary component of your second heart sound is really loud. It really sounds like a knock when you listen to it over the pulmonary region. You might hear tricuspid regurgitation. Your JVP will be elevated. Sometimes you can feel a right ventricular heave. And then don't forget the signs of associated conditions. So if they're sitting there with the little puckered mouth or the telangiectasia, signs of liver disease, other sort of sclerodactyly, think about the pulmonary hypertension. Okay. So how we diagnose it. So the first thing you always do as a cardiology is clinical assessment. So your good history, good examination, and by that point you should be sort of thinking, oh, you know, this really looks like pulmonary hypertension. You can do ECG. I'll show you ECG, different ones later. Spirometry with transfer factor, so especially the carbon monoxide transfer. Chest X-ray. It's gone out of favour a bit doing a chest X-ray in clinic nowadays, but it's pretty useful. Echocardiogram is the one that we all do, isn't it, to give us the answer. Once you've done your echo, you can think about a VQ scan, high-res CT, you might do a CTPA, and then after that you can think about sort of risk stratifying and looking at how limited the patient is. So you can do BMP, pulmonary angiogram if you're thinking about CTEPH, exercise tests, so we use shuttle walk tests usually, right heart catheter, which we'll talk about in a minute, MRI, so much better than echo for right ventricular size and function. Overnight oximetry, so some degree of sleep apnea is really prevalent in these patients and really important to detect and to treat. And hopefully after all of that, you've got your diagnosis. So, echocardiography. This is going to be in all of your echo departments, I'm sure. And in all the echo reports now, it comes out with a low, medium or high probability of pulmonary hypertension. And I'm not quite sure how much that gets taken into account when it's being looked at. What I would say is whenever you're looking at the TR, make sure they haven't got right ventricular outflow tract obstruction. Because if you've got that, TR doesn't mean a thing, does it? Okay, for the pulmonary pressure. But that just gets missed quite a lot. So they're looking at your TR Vmax for your first thing. So if it's less than or equal to 2.8 meters per second, it is really unlikely that you have pulmonary hypertension. If it's greater than 3.4 meters per second, it is really likely that you've got pulmonary hypertension. And then you've got all the bits in the between, and that's when you look for your other features on the echo to support your diagnosis. Okay. And they include, so you look at the ventricles, so is the right ventricle dilated more than, so is it bigger than the left ventricle? You've got this eccentricity index of the left ventricle. I'll show you a really nice example of that. So if you think about your left ventricle, it should be concentric and nice and circular in your short axis. When you've got that marked septal flattening, you get that sort of squished down D-shaped left ventricle. Pulmonary artery. So you can look at your acceleration time in your outflow tract. So if it's less than 105 milliseconds, then it's suggestive of raised pulmonary pressures. Your early diastolic pulmonary regurgitation velocity, and your pulmonary artery diameter as well. So if it's greater than 25 millimeters, that's dilated. And then you look at your IVC, about whether you've got inspiratory collapse, and your right atrial area. So the end systolic area is greater than 18. It supports your diagnosis. So, hopefully these will all play. So, it's quite an extreme case. So this was a young man who's in a bit of trouble. You can see he's got pericardial effusion as well. So, from here you can see really dilated right ventricle, this is what I mean by the eccentricity index. So it's really squished. So if you look at that diameter to that one, it's greater than 1.3. And he's got this massive right atrium, so the area was 23.7. You'd also probably notice that he hasn't got much of an atrial septum, so he's got a big ASD, and he's got pulmonary hypertension secondary to that, with previous heroin abuse and cocaine on top of that, just to really kickstart it. So they show the nice features there. So that was just to distract you from the previous slide to see if you've remembered. So which of the following, I'm not going to read all these out because there's lots of numbers, which of the following would suggest high probability of pulmonary hypertension on echo? Okay. Okay. Fantastic. So that's right. So it's that TRV max. So go straight away. It's over 3.4 meters per second. So this is high probability, and then the other factors there all support it. Okay. So right heart catheter. What I would say is that this should be performed by an experienced operator. And the pulmonary hypertension centres would rather do these themselves unless you are really, really confident. So unless you know exactly what it is they're looking for, I would get to the point where you think, yeah, I think this is pulmonary hypertension, and then refer on, okay? Otherwise, the patient will end up having a second procedure. Each one carries a risk for the patient, okay? So right heart catheter is your gold standard diagnosis of pulmonary hypertension. So it's going to confirm your diagnosis, and it's also going to assess your severity of the hemodynamic impairment. Okay. So the direct measurements you get are your pulmonary artery pressures, your cardiac output, your cardiac index, your wedge pressure, RA pressure. You should do a SATS run to look for any shunts. So as a bare minimum, we would expect SATS in the pulmonary artery, high SVC, IVC, and then also an arterial. Vasoreactivity with nitric oxide, that's only for people who have got idiopathic pulmonary hypertension or hereditary pulmonary hypertension, so you wouldn't do it routinely. And that's trying to identify who might respond to calcium channel blockers. Okay. From that, you can then have derived measurements of your transpulmonary gradient and your pulmonary vascular resistance. And then that's just for revision. These are your normal values. So if you look at your mean PA pressure, normal, if you look, it's about 13 plus or minus 3, up to 20 is considered normal. So you've got that slightly grey area, because we said that pulmonary hypertension was greater or equal than 25. So you've got that sort of 21 to 25, where it's slightly in a grey area. And what I would say is they shouldn't be just ignored and said, oh yeah, that's fine, that's normal, especially if they've got conditions that put them at risk. Okay, so if they've got liver disease, if they've got connective tissue disease, those are the ones you should be watching like a hawk. Okay, so here's a case. So we should get the diagnosis from the first line. 38-year-old lady, moved to the UK 2 years ago from India. This is 4 years ago now. Diagnosed with a hole in the heart in infancy. Parents never told her about it until she was older, never had any intervention. And she went to a local hospital in May a couple of years ago with hemoptysis, bright red blood. So when I saw her, clinical assessment, she was breathless at rest. So sometimes just getting up onto the couch, they're really sort of trying to catch their breath. Properly cyanosed, the oxygen saturations were 83%. She had a right ventricular heave, loud P2, no murmurs at all. And this was her ECG. Okay, so she's got marked right axis deviation. She's got P pulmonale, so she's got these sort of tall, nicely seen in lead 2, these tall tented P waves. Hasn't got RVH yet or RV strain, but she's got good going right axis deviation. Okay. Chest X-ray. This is a beautiful example of pulmonary hypertension on chest X-ray. So you get this really big, large central pulmonary arteries and this pruning, so the peripheral vessels are sort of all peter out, and you get those big proximal vessels. echo. I haven't got the best echo windows, sorry, but you can see here that she's probably got, the right ventricle looks dilated. Aortic valve. Those of you see there's something missing about here with flow across it. Looks like it's going both ways. And then on the apical forechamber, you can see that the right ventricle is significantly dilated. Again, you've got this marked septal flattening with this eccentricity index quite high. Pulmonary arteries, beautiful images of the pulmonary arteries, really dilated pulmonary arteries. And then your TRV max is 4 meters per second. So what's the diagnosis? So she had a VSD. Well, why has she got pulmonary hypertension? This is Eisenmenger syndrome, absolutely. So this is Victor Eisenmenger, who it's named after. He didn't have a clue what it was. He found it on a post-mortem and completely got the wrong end of the stick. Does anybody know who this is? This is Paul Wood, who was consultant cardiologist at Brompton in the 50s, there in front of the Brompton with his fag in his hand, as all cardiologists should have, clearly. And he put all the findings. There'd been lots of, since 1897, I think it was, Eisenmenger first described the post-mortem findings. There'd been lots of hypotheses about how it all came together, but it was Paul Wood in 1958 that, in his Croonian lectures, that put it all together. Oh, no, it's stuck. Sorry. So that's just a large, I won't talk much about Eisenmenger's because it'll be covered tomorrow, but it's a large communication between your systemic and pulmonary circulations at atrial, ventricular or arterial level, high pulmonary blood flow, pulmonary vascular remodelling with this high pulmonary vascular resistance, and you get the reversed and bidirectional shunting. So these are just showing quite impressive clubbing, with differential clubbing there, and this shows their very high hematocrit when you spin down their blood. So, case 2. 63-year-old woman, antiphospholipid syndrome and protein S deficiency, recurrent pulmonary emboli, and she comes to you with progressive shortness of breath on exertion. She has sinus tachycardia. Echocardiogram done in clinic shows dilated right ventricle, impaired function, systolic septal flattening, reduced pulmonary acceleration time, and her TRV max is 3.2, so in that sort of bit in the middle. So what would your next investigation be? VQ, yeah, you could do VQ, CT pulmonary angiogram. The guidelines say do VQ, but not every hospital does VQs particularly well. Our hospital, we would tend to do a CTPA first, so I don't think we'll do one of those first. These aren't actually the patient, they don't come with the same one, by the way. But this one shows you've got sort of dilated right ventricle, hypertrophied, you've probably got some thrombus here as well in the pulmonary arteries, really dilated PAs here. This is called your mosaic perfusion pattern, which is characteristic of CTEPH. Okay. So what would the next step be? So would you commence on warfarin and see with repeat echo in 6 months, because the TRV max wasn't that high? Would you start sildenafil and warfarin? Would you refer to the National Pulmonary Hypertension Centre for right heart cath and consideration of pulmonary endarterectomy? Would you refer to the ACHD team for atrial septostomy? Or would you start riociguat because you know it's licensed for CTEPH? Almost there. Right. Okay, absolutely. So these are the ones. There is a defined treatment that we'll talk about. These ones, anybody with a high suspicion of CTEPH should be referred to the Pulmonary Hypertension Centre and then considered for pulmonary endarterectomy. So when to suspect? So is this going to... It's not playing, sorry. 45-year-old woman, known systemic sclerosis. Straight away you're thinking, oh, about 9% of people. with systemic sclerosis developed pulmonary hypertension, progressive shortness of breath, now limited to around 200 metres on the flat, and an echo shows dilated right ventricle, RVH, TRV max 3.1 metres per second. So lung function test, she's got a very reduced DLCO, shuttle walk test really limited at 180 metres, and she has a right heart cath that shows mean PA pressures 41 millimetres of mercury. So this is pulmonary hypertension, arterial hypertension associated with connective tissue disease. That's group 1.4. And the reason why I've shown that case is that when I saw this echo, I went back through her previous investigations, and she'd had these findings for 5 years with this sort of progressive breathlessness that nobody had acted on, even though she was systemic sclerosis. So on average, there was a delay of 2 years between the onset of symptoms and the diagnosis. So think anybody with the unexplained progressive exertional breathlessness, consider is it pulmonary hypertension, and then whether you should be doing routine screening for high-risk groups, such as systemic sclerosis. Some hospitals do. Potential liver transplants, we see a lot of them at the QE or post-PEs. This is a lovely graph showing that the disease can progress even when you've got very minimal symptoms. So even those mildly symptomatic patients can have impaired hemodynamics. Okay. With the advent of drug treatments, risk stratification is becoming really important, and sort of that disease-targeted therapy. So think about your risk stratification. So this is from your ESC guidelines again, and it's looking at things like presence of right heart failure, progression of symptoms, functional class, 6-minute walk distance, BNP, all those things you would do routinely, and then just try and work out where they come. Do you need to escalate their treatment? So how do we manage it? So within the UK, there are the following. These are the designated pulmonary hypertension centres. So as I said, I work with Sheffield and the Royal Hallamshire Hospital. There's Glasgow, Freeman in Newcastle, Papworth, and then within London, there's the Royal Brompton, the Royal Free that does the rheumatological conditions, and Great Ormond Street for the children. Don't always just go straight for the drugs. Think about your general management. So they should be encouraged an active lifestyle, but avoid strenuous activities. So exercise within your comfort limits, annual flu vaccination, avoid routine venesection, make sure they've got optimum iron stores. Think about contraception. You don't want these patients, the female patients, to get pregnant, ideally, because it's significant risk in pregnancy. You can use oxygen for symptomatic benefit. There's no effect on survival. Talk to them about lifestyle modification, work, support them through benefit application. Other things are anticoagulation. Are they at high risk? Do they need full warfarinization or DOAC? Do they need diuretics, oxygen? Iron supplements, mentioned again. So iron deficiency is associated with a reduction in your iron capacity, even if you've got no anemia. So if your hemoglobin is normal but you're iron deficient, you can still have significant reduction in your exercise capacity. Think about calcium channel blockers if they've got a positive vasoreactivity test. So we now have targeted treatment for pulmonary hypertension, and it's these groups down here that have got defined treatment options. So your pulmonary arterial hypertension and your CTEPH. Okay. And then we go back to that diagram that I showed earlier, and we've got these drugs that are affecting, sort of working on each of the pathways. So on the endothelin receptor antagonists, we've got the bosentan, embrisentan, macitentan. Acting on the nitric oxide pathways, you've got the phosphodiesterase 5 inhibitors, which is sildenafil, tadalafil. There's also riociguat now, which is a cyclic GC stimulator, and that's licensed for recurrent CTEPH. And then you've also got the prostacyclin agonists. So you've got the iloprost, so inhaled iloprost, treprostinil, epoprostenol. Selexipag is a fairly new drug that's an oral prostacyclin derivative that's now you are able to use in the UK. England was the last to license it, but we can use it now, but not if you've got a shunt. So this is the guidelines for treatments from the ESC, and it's really looking at sort of initial monotherapy. So I keep pressing number one. You can do initial monotherapy, which in this country would be sildenafil at first line, unless there's contraindication. If the patient falls into the high-risk category, then you might start them up front on combination therapy, such as an ERA, so besentan plus sildenafil. Or if they're very high risk, functional class 4, you might start them on a prostacyclin up front, and then you can escalate it up. So if you're on single therapy, increase it to dual therapy and then triple therapy. In this country, to be on triple therapy, you have to be considered suitable for lung transplants. Okay, so you don't have to be on the list, but you have to be deemed suitable. Okay. So other treatment options. So we talked about CTEPH. It's the treatment of choice for CTEPH is a pulmonary endarterectomy, and the patients do really well afterwards. In the UK, the only centre for this is Papworth, so again, you're really sort of focusing down your speciality. For inoperable CTEPH or persistent pulmonary hypertension despite endarterectomy, you can consider balloon pulmonary angioplasty. And again, the only place that does that at the moment is Papworth in this country. Transplant. Since we've had selective pulmonary vasodilators, there's been a delayed and decreased referral to the lung transplant programs. Most of these patients would receive double lungs. If you had Eisenmenger syndrome or other congenital defects, you could have either a heart lung or a lung with intraoperative repair of the defect, if it's a simple defect. And the survival post-transplant, 75% at 5 years. So that's up to 66% at 10 years. Balloon atrial septostomy, this is really your bailout procedure. So it's a palliative or bridging procedure, all for those on the lung transplant waiting list on maximal medical therapy, but incredibly symptomatic. So it's for WHO functional class 4 with heart failure refractory to medical treatment, or if you've got severe syncope. Don't do it in end-stage patients if the mean RA pressure is greater than 20 and SATs at 85%, okay, because the patient will fall in a heap in front of you and probably die. So summary. So there's lots of different causes of pulmonary hypertension. This should be your take-home message, is that you have to consider and confirm or exclude the diagnosis early on, especially if you've got an at-risk condition, so your connective tissue disorder, your congenital heart disease. The group 1 patients may be suitable for targeted pulmonary vasodilator therapy, and what I would say is if you have anybody with that high suspicion or you've already confirmed the diagnosis, refer early to a specialist centre. Sorry.
We're going to have time for questions. Can I ask you a really simple question that I should know the answer to? So the relationship between systemic pressure and pulmonary pressure. So for example, someone may have a mean PA pressure of 30, but they've got hypertension with a pressure of 180. Is that still pulmonary hypertension?
Yeah.
It is. So they should be independent of each other. Yeah. The second quick question is the role of anticoagulation prophylactically. So the non-CTEPH patient with PAH, should they be anticoagulated?
So there are some, so the really at-risk groups are idiopathic and those that are related to drugs. And I think you'd have a low threshold to anticoagulate those patients. Other patients, so our Eisenmengers, we do it on an individual patient because, yes, they're at risk of having thrombosis, but they're also at risk of hemoptysis, which would be pretty catastrophic anyway, and if you're on warfarin. But so it's the idiopathic, drug-related, very, very low threshold, other patients, individual.
Very good.
A practical question about the right heart study. When you measure the pressures, you measure 5 times, you measure 5 different numbers. Yeah. How do you choose? How do you, is it end sort of expiration?
End expiration. You don't need to hold expiration, but end expiration, and you should do the mean of 3. I think the guidelines recommends.
So you ask them to hold their...
No, you don't need to do... You just ask gentle just normal respiration, but you measure it at sort of held... Not held, but just end expiration. Yeah, but you don't need to... Otherwise, you're going to get them to take a deep breath in and out, and it's going to affect it. So just normal respiration we would do.
I would encourage you not to use thermodilution outputs. This you do a thick cardiac output in oxygen consumption in these patients.
Yeah, but the guidelines say use thermodilution.
we have the opposite. That's very interesting. Go ahead.
Just a question about case 2. I think I remember seeing that the estimated PA pressure on the Doppler was It's 3 meters per second.
3.2, yeah.
Okay, so it's below the absolute number.
Yeah.
So this group in a DGH is a very large group of people. They've got lung disease, they've had the echo, there they are, and we're trying to make a call on it.
Yeah.
Do you think we should be cathing those patients to make, if we're not sure? I mean, we look at the echo and look for right heart and stuff, but there's still a few cases coming through where the echo Doppler has not given the correct diagnosis.
Yeah, I mean, I think
Patients, right?
Yeah.
it's a huge number, and I think you look at the echo reports, and I think there's huge numbers that are missed. And I think if you've got that between 2.8 and 3.4 with other features, and the patient is breathless, then I would certainly investigate further. Yeah, so if they've... It depends what the history is. Yeah, yeah. But yes, I would have a low threshold for cath. Yeah.
I just got one question regarding the prognostic benefit among all the drugs you have mentioned in your slides. So which is the most benefit drug for the patient among all these? Start off with the sildenafil and you go on the ambrisentan or bosentan or other fancy drugs.
I mean, it's difficult because there's not one sort of one, you know, head-to-head comparisons, but they've all got prognostic benefits for them in certain conditions. Okay, so you've got all three. So it's difficult to say which one's going to give you the best prognosis, because you know you can look at the prostacyclins, they'll be the strongest, but they've got complications. So if you've got IV, you've got the infections and that. So it's a stepwise.
So just clarify for me, then it's another question here. So they go to the lab, they have pulmonary hypertension, normal wedge pressure, you inhale nitric oxide, and you see let's say you don't see a response, so there's not a 20% reduction. That means they cannot get a calcium channel blocker, is that right?
Yeah.
There's no benefit to a calcium channel blocker in those.
Yeah.
So the importance of a proper full workup,
and
it does dictate your treatment.
Yeah, and then the guidelines say I wouldn't do that vasoreactivity unless this is idiopathic, unless you have strong suspicions of idiopathic.
Very good.
Or hereditable.
And if the wedge pressure is high, you'd give them a nitroprusside in the lab, see it drop, and see if the PA pressure drops in unison. Okay, very good question.
Shouldn't we correct the TR for age?
For age?
Yeah, because many elderly people, TR increases with age.
But your TRV max shouldn't.
You're sure?
Yeah, I'm not sure, but if you look, I mean, the guidelines don't, you know, it's over 3.4, it's pretty strongly suggestive.
Rio Sigwat in the US is $100,000 a year, by the way. I don't know what it's like over here, but it's kind of prohibitive.
I think I've got 3 patients on it out of a large population.
More questions?
Not greatly
Let's
tolerant.
shout it out, please.
Just a quick question, your choice of anticoagulation.
Oh, we should have like 3 days on anticoagulation next year, I think. It's really important. So you choose. So whatever you tell us now, this will dictate our practice moving forward.
I've got to say, we're using DOACs more. Yeah. You know, we've used warfarin for many, many years. Same with everything, isn't it? You haven't got the evidence base, but common sense says that actually DOACs are probably just as good.
Yeah, 2 more questions. Hand up at the back, but shout it out.
Just there's lots of other sorts of rarer causes. How often do you go hunting after the schistosomiasis?
Me, never.
So did people hear that? So I guess it's the effort to yield ratio of chasing after these rare causes.
No, I mean, it's all down to this is why your history is so important. You know, if it's schistosomiasis, if they've spent the last 2 years in diving in Lake Malawi, then yes, I'd go hunting for schistosomiasis. If they've never been out of this country, but they used to take amphetamines or appetite suppressants, then I wouldn't go looking for it. So, yeah.
Time for one more. I saw a few hands go up. Maybe the schistosomiasis was the only... Oh, go ahead.
Just a quick question. We often get patients sent to us for, breathlessness, and we've got to do the neck. How happy are you if you don't find a tricuspid regurgitation? How happy are you with the values that you're getting from the pulmonary outflow? If you don't have...
Yeah. You don't...
How good are they?
It's a screening tool, isn't it? So it's looking at everything all together, and it's looking at the history. You know, I saw a chap who his echo was really very little to say on it, and just because he didn't improve PE years ago, and we did a right heart cath because his echo was just not really helping. We did a right heart cath, mean PA pressure was 23, and then actually he ended up having significant CTEF. So it's just looking at everything. I wouldn't go, I wouldn't look at an echo and then say, right, that's all the information I need. You can't do that.
That is just fantastic. Thank you again for your wonderful talk today. Appreciate it.